Welcome to session 3 on clinical manifestations of tuberculosis. Urogenital TB. Urogenital TB refers to TB of the male and female genital tract and the urinary tract. This accounts for 4% of all EPTB cases annually in India. Usually it is an insidious disease. Presentation depends on the affected site and stage of the disease. There are 3 broad categories of urogenital TB. Urinary TB, which refers to TB of kidneys, ureters and bladder. Female genital TB, which refers to TB of uterus, fallopian tube and ovaries. And male genital TB affecting the epididymis and the testis. So, the urinary TB usually presents with lower urinary tract symptoms like frequency, urgency and nocturia. Dysuria or hematuria for more than 2 weeks not responding to antibiotics. Fever, weight loss and night sweats may be present. Initially tubercles are formed in the kidneys which heal spontaneously or as a result of treatment, and they may enlarge after many years of inactivity and rupture into the nephrons producing basiluria. Female genital TB. This is an important cause of infertility. This is seen in 12% of patients with pulmonary TB and accounts for 15 to 20% of all extrapulmonary TB. Women in reproductive age group, it's 15 to 45 years, are the most affected. Infection can occur through 4 main routes: hematogenous, where the primary pathology is in the lungs; descending direct, lymphatic, and very rarely primary infection can occur due to sexual transmission. The organs affected are fallopian tube, uterine endometrium and ovaries, and very rarely cervix, vagina and vulva are also affected. Female genital TB is usually asymptomatic. In premenopausal women, infertility is the most common presentation. Menstrual irregularities can also happen in the form of menorrhagia, metrorrhagia, hypomenorrhea, dysmenorrhea. There may be abdominal pain or presence of pelvic mass. Abnormal vaginal discharge can also be there. There is fever, weight loss and night sweats. Ectopic pregnancy and cervical or vulval lesions are rare presentations. So, a high index of clinical suspicion is required because no symptoms other than infertility may be present. In postmenopausal women, there is vaginal bleeding, leukorrhea and pyometra, and malignancy should be an important differential diagnosis in these cases. Now, coming on to male genital TB, this is associated with renal TB, 60 to 65% of the cases. The most common sites affected are epididymis, prostate, seminal vesicles and testicles. Patients may present with scrotal pain or swelling for more than 2 weeks not responding to antibiotics. There is presence of discharging sinuses in the scrotum. Fever, weight loss and night sweats are rare. So, coming on to TB of the skin. This is very uncommon. It accounts for 1.5% of all EPTB cases. The main cause is Mycobacterium tuberculosis and Mycobacterium bovis, and very rarely it can also be caused by BCG. This usually coexists with pulmonary and lymph node TB. Patients presenting with ulcers or discharging sinuses over lymph nodes, bones and joints, a persistent asymptomatic raised reddish or reddish brown skin lesion more than 6 months duration with scarring at one end, and persistent warty skin lesion of more than 6 months duration should be evaluated for presumptive cutaneous TB. TB of the skin, the most common manifestations are lupus vulgaris and scrophaloderma. Lupus vulgaris is commonest and is prevalent in children. The spread is usually hematogenous. It can be seen in both immunocompetent and immunocompromised. The common sites affected are face and extremities, and the lesions are well demarcated, skin colored to erythematous plaque with evidence of healing and scarring in one area and activity in another. The other common manifestation is scrophaloderma. This also occurs through hematogenous spread. It can be seen in both immunocompetent and immunocompromised. It can also arise due to a contiguous extension from local cervical lymph node. It is associated with systemic disease. In HIV infection, we may see papules, nodules, vesicles or indurations. The third variety is tuberculosis vericosa cutis. This is also known as warty TB. it affects the hands and feet. This is due to direct inoculation of bacilli at sites of skin trauma. Verrucous papules and plaques are seen, and the surface shows fissures or clefts that may extrude pus, and perilesional erythema is present. The other rare varieties include nodular vasculitis and erythema nodosum, post-vaccination lupus vulgaris, lichen scrofulosum and papillonecrotic tuberculate, primary inoculation TB, acute miliary TB, orificial TB and tuberculous gamma. Next is ocular TB. The incidence of TB in patients presenting with uveitis ranges from 0.6 to 10%. This may cause moderate to severe visual impairment. Almost all structures in the eye are affected. The most common ones include uveal tract and the choroid. The spread is hematogenous. Primary infection is very rare. Signs and symptoms are consistent with anterior, intermediate, posterior or pan-uveitis. It includes red eye, blurred vision, photopsia, irregular pupil, floaters and photophobia. Ocular TB, the most common manifestation is posterior uveitis with choroidal involvement. The choroidal involvement is in the form of choroiditis, subretinal abscess, tubercles and tuberculomas. Choroidal tubercles are small grey to white to yellow nodules which are single or multiple, seen at the posterior pole. These may grow into a choroidal tuberculoma, and the presence of choroidal tuberculoma may be a diagnostic clue to miliary TB. TB of the breast. The incidence is 3 to 4% in endemic settings. It usually affects the young lactating multiparous women. It can occur either as a primary infection or as secondary infection, which is more common. Primary infection is through direct inoculation of the breast by Mycobacterium tuberculosis through skin abrasions. Secondary, which is more common, can occur either through lymphatic or hematogenous route. Retrograde extension from the axillary lymph node is the most common route. Clinical presentation is atypical and histopathological evidence is suggestive. TB of the breast usually presents as solitary, ill-defined, unilateral hard lump in central or upper outer quadrant of the breast. Thus, this becomes indistinguishable from carcinoma breast. This can progress to a tuberculous ulcer and abscess with or without discharging sinuses. Patients may present with mastalgia with or without increased breast nodularity, and axillary lymph node involvement is also seen. Based on the clinical, pathological and radiological features, 3 types are identified: nodular, diffuse or disseminated and sclerosing. Now, coming on to the TB of the ear, nose and throat. This constitutes less than 5% of all cases of EPTB. This involves the larynx, ear, pharynx, oral cavity, salivary glands, paranasal sinuses, nasopharynx and the thyroid gland. TB of the larynx. All patients with laryngeal TB have radiological evidence of pulmonary TB and are sputum smear positive. Patients often present with hoarseness of voice. Pain is also an important feature which may radiate to one or both ears and may lead to odynophagia. It can be infectious unlike other forms of EPTB. TB of the ear and oral cavity. TB of the ear presents as chronic suppurative otitis media not responding to antibiotics. Hearing loss is disproportionate to clinical appearance and it may be complicated by facial paralysis and inner ear involvement. Oral TB, the lesions are usually ulcerative and painless, sometimes with a necrotic base and discharge. Tongue is the most common site affected and it accounts for nearly half of the cases of oral TB. TB of the oropharynx, paranasal sinuses and the glands. TB of the tonsils, which is more common, presents as asymmetrical enlargement with ulceration. TB of the cervical spine can also extend as retropharyngeal abscess and causing pain on swallowing. Sinonasal TB is very rare. It usually presents with nasal obstruction, bleeding and running nose and lymphadenopathy. Salivary gland TB is also very rare, associated with immunosuppression and swelling of gland. Parotid gland is the most commonly affected. Thyroid gland TB is very rare and the presentations range from isolated nodules to thyrotoxicosis. Now, coming on to the next entity, that's congenital TB. This is rare. This is transmitted to fetus hematogenously via umbilical vein or by fetal aspiration or by ingestion of infected amniotic fluid prior to or during delivery. Onset is usually between 2 to 9 weeks after delivery, and the symptoms may mimic bacterial sepsis, which include failure to thrive, abdominal distension, fever and irritability, respiratory distress, lethargy and poor feeding. Hepatosplenomegaly and lymphadenopathy are commonly seen, and the diagnostic criteria include proven TB lesions in infant plus one of the following, that is lesions occurring in the first week of life, a primary hepatic complex, maternal genital tract or placental TB, and exclusion of postnatal transmission by investigation of contacts. Abnormal chest radiographs with up to 50% showing a miliary pattern may also be observed. So, the key messages of this session on clinical manifestations of TB include that TB primarily affects the lungs, other organ systems can also be affected, lymph node TB and pleural TB are the commonest forms of extrapulmonary TB. Extrapulmonary TB are more common in people living with HIV. Clinical manifestations can be systemic and or organ specific. Thank you.